Good afternoon, everyone, and welcome to Systems and Sustainability Echo. My name is Shreya Prasanna, and I will be facilitating today's session. Some housekeeping before we get started. These sessions are enabled for live closed captioning. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. We are recording these sessions for later distribution through the BeWell YouTube channel. Any info you put in the chat will not be shared on those recordings. As always, please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to join by video, especially for the discussion portion of our sessions. That said, regardless of how you've shown up today, we are just happy you're here to learn alongside us and share your perspectives in today's discussion. Because there are a lot of us here, we ask that you keep your comments brief to allow space for others to speak up as well. You can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or the discussions, and that includes sharing names, exact dates, relationships, or medical information in a way that someone could identify that person. To help us with attendance, please enter your name, affiliation, and email into the chat. We appreciate your support in helping us fully capture this record. To all the BeWell Texas providers, please make sure that you identify yourselves during this session, or if you're joining via phone, please email your phone number and name to bewelltx@unisca.edu. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it out for a drawing, to be entered into a drawing for a $30 Walmart gift card, and to give us some feedback on ways to improve these sessions. Our didactic today is about an introduction to process improvement and the NIATx model of rapid cycle PDSA testing, and will be presented by Mathew Roosa. After that, we'll have some announcements and then hear a systems case from our learning community. As always, I encourage you all to share your questions, feedback, and guidance for the questions raised by our case presenter today. Remember, we are all teachers and learners in this space. And with that, we will do some introductions. Matt.
Hi, everybody. I'm Matt Roosa. It's good to be with you today. My background is in clinical social work, agency administration, governmental planning. Now I work as full-time as a consultant in the areas of quality improvement, process improvement, a lot of evidence-based implementation, coaching. Thanks. I will hand off to Kathy.
Good afternoon, everyone. So glad to see everyone. I am Kathy Hudgens. My background is integrated care, both for behavioral health and substance use disorders into primary care. I do also am a consultant for state health policy, and I also teach occasionally at Arizona State University, and do work in a lot of program and process improvement and public health. Thank you.
Thank you so much for joining us. Leslie.
Thank you. Hi, everybody. I'm Leslie Manson. I'm a licensed clinical psychologist, and my background is in integrated substance use, mental health, behavioral health, and medical care treatments. I provide consultation in the U.S. and internationally on those topics, and I'm also a clinical associate professor and chair of integrated care initiatives at Arizona State University. Thank you.
Thank you so much. Tonya. Tonya, you're muted.
Sorry about that, guys. I'm not used to having to talk in this. Thank you. So I'm Tonya Granger. I'm with Texas Clinic Healthcare System. I am the alternate funding coordinator for BeWell, as well as a counselor for our OTS program. My background is really, and thanks to you all, I've really moved from an abstinence-based mentality over the last 5 years into a much more harm reductionist. And I love it. The umbrella is so much wider with this mentality. So thank you all for that. So that's who I am. Thank you.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am the program coordinator for CSTEP. Welcome, everybody.
Thank you. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm the program coordinator for CSTEP. Thank you for joining today.
Thank you. And with that, we will move on to our didactics. Matt, please take it away whenever you're ready.
All right, thank you very much, Shreya. I'll go ahead and share screen and pull up our slides for our presentation today. Sorry, folks, having a little bit of an issue here with visuals. Hang on one second. All right, should be good there. Excellent. All right, so yeah, we're going to talk about an introduction to NIATx and rapid cycle process improvement, give you a little sense of the history of this kind of a model. There are other related models in this world of process improvement. So this is a model that's been around for about 20 years plus, and I've had the opportunity to be involved with it for that length of time. So let me just give you a little quick history, and we'll spend about 15 minutes or so talking about this model before we shift on to the rest of our agenda. I want to tell you a little bit about where process improvement comes from, tell you a little bit about some of the tools that we use with this NIATx model, and then hopefully you'll have a bit of an introduction and give you a sense of where you can get more information about it as well. So the roots of this NIATx model come from people like Deming. Some of you are probably familiar with W. Edwards Deming, who was a data scientist who was incredibly influential in the post-World War II era. A lot of work to redevelop Japanese industries following the war and how they were, of course, destroyed as a result of that war. And also in America in the late 40s and 50s, a lot of the major industrial improvements and manufacturing in particular improvements. This work that I do with NIATx, although it's occurring in health and human services, has its roots in engineering. The folks who designed this model and developed this model are engineers, process engineers from the University of Wisconsin-Madison, which is where it's headquartered and where the NIATx Foundation has its headquarters. So the work of Deming and the work of process improvement engineering is all about thinking about everything as a process. Everything you do, whether it's developing a new program or making a peanut butter sandwich, can be defined as process steps, specific things that you do in a sequence. And when we think about customers' experience and customer satisfaction, think about all the folks who you serve, the things that they have frustrations with, that they complain about, are process. Very rarely do you have a client or a patient or customer who comes to you and says, I wasn't a big fan of your use of a particular practice or evidence-based orientation. Usually they don't have the experience to know or to be able to critique those things. Mostly they think about things like, why did it take so long? How come the bill was this much? How come you didn't talk to me about this? Why did I have to wait? I didn't like how I was welcomed at the window, or what someone said to me. These are all process experiences, and that's what makes the difference. And if we think about our other customer service experiences, we tend to be more frustrated with the process than we do with the product. So that's a key understanding for us. If we want to fix the problems, we have to understand and improve the process. And we have to be data-driven in doing that. So this NIATx model is very much a data-driven decision-making process. And it's key for us to know and understand our customers and involve frontline workers. One of the other key heartbeats of this model is to ensure that you are engaging your line workers, that it's not just a top-down administrative decision-making. We work on a model of small change teams that incorporate the people who are doing the work, who have the closest connectivity to the customer. And we use the word customer a lot to represent all the possible customers who you might have. Those are the people who are receiving services. Those are the people who maybe pay you for services. Those are the people who refer individuals to you for care. So you have a multitude of different customers. So we like to use that kind of customer service orientation with this model. So we have 5 core principles. These principles came about as a result of the founding research that was done at UW-Madison. Todd Molfenter and Dave Gustafson, who were the originators of this model, funded developed this model and funded a bunch of agencies. I got involved because I was a director in one of those agencies that was funded through SAMHSA and through Robert Wood Johnson Foundation to get this thing started. And I've kind of stuck around with it since. And there was some solid research done, analysis of hundreds of organizations and trying to determine what impacts quality as it relates to implementing change. And we came up with these 5 core findings that these were the variables that had the biggest impact for those organizations that were successful at making changes, and they became our 5 principles. Understanding and involving the customer, fixing key problems, things that keep the directors awake at night, things that are concerns for leadership, finding a powerful change leader. And we use that word powerful loosely, not necessarily formal power, but relationship power. Getting ideas from outside the organization and field. We like to look outside into other industries a lot to try to borrow best practices, and using rapid cycle PDSA testing. And I'll talk to you about what that means in a minute. Our number 1 principle is the number 1 principle. Understanding and involving the customer is really the heartbeat of the model and how we use it. So here's a quick sketch on what process improvement from the NIATx model is about. We come up with an aim. We think about change projects that we can do in relation to that aim. We have people and tools. We use executive sponsors who support the change. We have a change leader who leads a team of individuals. We use a simple sequence of tools, and I'll tell you about those in a minute: walkthrough, flow chart, nominal group technique, and PDSA cycles. And then we have a couple of rules. We try to make sure we measure. We're always trying to make sure that we use existing resources. We know that your systems are burdened and challenged as it relates to finance and staffing, so we don't want to add burden with process improvement tools. And so we try to be mindful of that and always thinking about sustainability in order to move the process forward. And these are those 4 tools in a sequence. So I want to take a minute and explain each one to you. There may be some familiarity that you have from other experiences. Maybe some of you have been introduced to this NIATx model previously. These are the tools that we found to be highly effective, and they represent a nice simple sequence. So we start with a walkthrough. And a walkthrough is where we have someone do a role play to see what the experiences is like from the customer's perspective. Then we draw a flow chart or a process map of what we learned when we did that walkthrough. Then we think about ways that we can come up with strategies that will impact whatever it is that we revealed through that walkthrough and flow chart. So we need a strategy. So we do brainstorming through the nominal group technique, and then we do a change project. We do that through the PDSA model. We often like to ask ourselves some kind of key questions, and these are the questions that you see here. So you can take a look at those 3 questions. That kind of gets us started in terms of thinking about what's the aim? Where do we want to start? What's the territory where we need to make an improvement? Who's a part of that? Who's involved with that area, so that we can kind of focus ourselves in a particular territory. Then we look to do that walkthrough and wherever we've focused ourselves. So one thing I'll always like to share is that we try to avoid the secret shopper orientation. Some of you may be familiar with that idea, where you sort of call your intake line and see how the intake workers are doing, and then you can talk to them later and say, "Hi, found out that you were doing something that's not that great, and we'd really like you to change it." We don't tend to prefer that model because it kind of has a trust damaging potential, and it's kind of sneaking up on folks. And the pushback I sometimes get is, "Yeah, but if you tell them you're going to do it, then they'll do their very best." And I always say back, "Yeah, that's what I want. I want their very best, because I'm not analyzing performance here. I'm analyzing process. I want the best product, because even the best product has process flaws in it. And that's what I'm looking for. Those are the things that we want to improve." So this is not a performance evaluation. Those are an important thing, but that's not what we're doing here. We're looking for evaluation of the process. Once we do the walkthrough, get some experience as a customer. What's it like to fill out your paperwork? What's it like to sit in your waiting room? What's it like to go through the process of being admitted into a service? Then we'll flow chart that. And we'll flow chart that from that customer's experience and draw a nice simple flow chart. We don't like complicated flow charts. We only like to use the elements you see here, simple boxes and arrows. You start somewhere, you end somewhere, boxes and arrows, and maybe a diamond if you have one of those simple yes/no decision points in the process. But keep it simple and draw a nice detailed map of the entirety of the sequence. Post-it notes are great for this because usually when you do it, you find that you put them in the wrong order and you have to move them around. So labeling Post-it notes and putting them up on the wall with the group, or you can draw it in whatever way is manageable for you, but a nice, clear and simple flow chart. Once we've done that, we can identify areas where we see some problems. And then once we identify those areas of challenge, bottlenecks, flow problems, places that are kind of stressful or that are confusing or that agitate the customer in some way, then we can start to think about how we might fix those, right? We're starting to generate ideas about how we might make improvements. So then we move from this flow chart into the idea of nominal group technique brainstorming. When I spend time, I can talk about nominal group technique brainstorming for a long period of time. And one of my key questions always is, when is brainstorming not so good for some people? Some of you will say, well, I always enjoy it. And others of you will say, there are times when it just, no, I don't like it. There are people who dominate things, or not everyone gets to talk. Some people don't share their ideas. Some people don't feel comfortable or confident. Sometimes it moves so quickly that I don't really get a chance to think about the question. All of these issues are addressed with these 4 key steps of the nominal group technique, which is really designed to create a broad list of strategies, a wide variety and a large list of strategies. And it's really well designed to be inclusive, to ensure that all parties have a voice. That's a really important value for us. So we start with silently generating ideas, have people simply answer the question, whatever the question is we're brainstorming, but doing that silently without any conversation with anyone else. Then we move on to round robin report out, where we go around the room, whether it's virtually or in a room together where you're in the same location. You can also do this asynchronously across time, where you do each step across time with a group. But we have people report out their ideas, and we like to go round and around so that no one person kind of has a dominant voice. Everybody kind of creates a tossed salad together where we share all the ideas. Then we discuss them for clarification, not for judgment, not for the thumbs up, thumbs down on the idea, but just to make sure everybody understands every idea. You can see how this is quite structured and requires a facilitation that's pretty active to make sure that everybody does these steps according to the sequence as I'm describing it. And then finally, we do voting. And typically we like to do voting with sort of a kind of two variable criteria, which is really about return on investment. How easy is the strategy, and what's the likely impact? So we try to do the green box upper left, high impact and easy to do, right? Those are the ones we want to do. We always try to avoid the things that have low impact and they're difficult. So typical return on investment thinking, right? And then maybe you might want to do the things in the yellow boxes, low impact, but it's easy. Maybe we'll do that. Difficult, but it has a high impact, high return. So maybe we'll do that. So if you give people this simple 2x2 criteria, helps them to think about what it means to define best idea when you're getting to the 4th stage where there's voting. And this is the only stage where there's any kind of judgment of ideas. We want to avoid any sorts of judgment, either positive or negative, throughout the process, again, so as to encourage everyone to feel really active and participating. So once we then come up with a strategy, that's when we move on to testing. And the way that we test it, that data-driven approach, is to use the PDSA, which really mirrors a simple scientific method. We want to look at one variable at a time: plan, do, study, act. So let me give that to you in a simple graphic representation. Again, data-driven always. We start out with a baseline. What's the measure look like at the beginning? Maybe we're trying to get more folks enrolled in a program. So how many people are we enrolling each week or each month before we test something? And then we come up with a goal, a stretch goal for ourselves that we would like to try to achieve in terms of that enrollment example. How many people would we like to see? What kind of an increase? Then we come up with our PDSA, and we come up with an aim statement where we want to improve this indicator measure, right? In this case, it's the number of enrollments, from a baseline to a goal by a certain date. We call this rapid cycle model. We like to think in terms of weeks and not months. Try to do these small, simple changes. Then we test it and we follow our results. That's the plan, do, study. How does this work? Does this particular strategy to increase the number of folks? And maybe there's an outreach program that we establish to see if we can encourage more folks to be enrolled in this particular program. And we're going to test that. And we see here with our example that it had a modest increase. That's where we then start to think about this trend and consider next steps. When we get to the PDSA phase, the action phase, we usually think of this in terms of 3 potential actions: abandon, adapt, or adopt. If we abandon it because it just didn't work at all, we can adapt it and adjust it a little bit, or we can adopt it if it worked wonderfully and it becomes our standard operating procedure. In this case, we might want to think about doing a multiple cycle. We do this a lot, where we continue to work on the aim and we change and work on a different strategy in a series. In this case, let's do a second strategy where we're going to create some additional incentive in addition to the outreach program. And then we'll test that. And in this case, we achieved our goal, which is great. And then, as you learned from the beginning of our conversation, sustainment is our key. How do we then sustain this? One of the best ways that we sustain it is that we continue to measure it. We periodically check the measurement. We create a data dashboard, which allows us to every month or every quarter keep an eye on this particular indicator measure, so as to know whether or not we need to implement any additional strategies. So that, in a nutshell, is this sequence of tools, right? Walkthrough, flowchart, and then moving our way toward coming up with a strategy through that brainstorming, through a nominal group technique, and then testing the PDSA. Sorry. So that, as I said, is in a short, quick nutshell, is the NIATx model. I'm always happy to talk with folks more about it. You can also go to www.niatex.wisc, W-I-S-K, as in University of Wisconsin.edu, where there's a nice series of resources that allow you to learn more about the model. And I'm always happy to chat with people about the model. We're using it. It's been used in thousands of places, and it's helped a lot of organizations to be really effective with their process improvement efforts. Thanks very much.
Thank you so much, Matt, for this very informative session and introduction to the NIATx model. And I am going to open up the floor to questions from our learning community here.
I have a question. In your experience, when you're working in this process and these steps, what can be the most challenging when you're working in an organization, in your experience?
Right, in implementing with this model, several things are common challenges. One is trying to make sure that the team starts with something that is small and simple, something that is manageable as it relates to measurement, and something that they can do in a relatively short period of time. There's a tendency toward overly ambitious change projects, or toward complexity, which involves multiple variables. Well, we want to overhaul X. And whenever I hear anything like that, I say, well, you may want to and choose to overhaul X, but that's not this model. In this model, we're going to be very granular and test a singular thing in a simple fashion with a clear indicator. And that's usually where folks will struggle. Probably the broader challenge is related to just the whole idea of doing quality improvement, process improvement work. It's something that you can put off because you have a crisis and you have an issue, and there's always patient or client care needs that are crises, and you cannot do quality improvement work today and it's no big deal, and you cannot do it this week and it's no big deal, and you cannot do it this month and it's no big deal, but at some point it catches up to you, right? And so having a team and leadership, that's where leadership sponsorship is so critical, right? That we build into the infrastructure of our teams this quality improvement, data-driven orientation. So it's part of how we do our team meetings. It's part of how we do our staff meetings, that we look at numbers and we track them and we try to test different things. So kind of building culture is one of the key challenges that some folks have.
Thank you very much.
Yeah, great question.
Thank you so much. And I see a question here from Andrea. Is this a model that can be applied to all organizations?
Yeah, this is by design a simple and highly useful model across a wide array of environments. It originated in substance use service environments. In fact, NIATx was an acronym to begin with, Network for the Improvement of Addiction Treatment, TX for treatment. But then we moved into mental health and broadly into human services, and now it's being used across a wide array of health and human service models. And if you're familiar, you know it has connectivity to other Lean, Six Sigma, IHI kinds of models of improvement. There's connectivity there. So you can really use it across a wide array of organizations to do change projects.
Thank you. And Matt, if you could please share that link in the chat, if you don't mind, for the resources
Yes, I will
on
absolutely do that.
NIATx. Yeah. I wonder if anybody here in the learning community has used this model before, or what have you used for quality improvement in your setting?
I do often hear that folks will say, well, we use Six Sigma models in our environment. I sometimes, when I do the comparison, I find that this NIATx model is more accessible when you're working with folks who don't have a background in improvement, in quality work, because it has a nice, easy on-ramp. And so I think it is, because we do try to have active, direct practice staff involved, that we always try to keep the model simple and easily accessible to folks who have never done that kind of work before.
Matt, I have a question. Does NIATx offer trainings for organizations so they can, better use the tools that they offer?
Yeah, there's a good bit of training. I work in part with the TTCs at the University of Wisconsin, addiction, mental health, and prevention TTCs, all of which provide NIATx related training, because that is where NIATx was founded. There's also, for those who are not within that Great Lakes TTC region, there's the NIATx Foundation. You can just kind of Google NIATx Foundation. And I also work through the NIATx Foundation. And we do that nationally, internationally, to support organizations, systems, states, regions, cities who want to work on this improvement model.
Thank you. Leslie, I see your hand raised.
Yeah, I was just going to comment. I do like the NIATx model as well. I think it's really has a lot of ease ability to bring into most types of healthcare settings, and predominantly because although we do have some members that will be like, oh, I've learned lean and I'm, certified in this level, or I have this, or I did the IHI modules, or people come in with different backgrounds, but then there's also different language that is aligned with those types of trainings. And that can sometimes be confusing to other team members, where NIATx is much more like simple on the ground. Hey, let's get this done. It does align with simple PDSA cycles. So it gives you kind of this format and grounding to be able to kind of run with it. That's how I see it. So I always find it much more helpful and easy for people to really just kind of adopt and bring on and run with it, so that they can have a way that they're really looking at their healthcare center for improvements and advancements. So just kind of.
I think that's well said, Leslie. I'm a fan of the African proverb. If you want to go fast, go alone. If you want to go far, go together. And these models, I think, help you to go far, because they do, as you said, engage everyone and create that sense of team and alignment and connectivity. You may have individuals within your system who have a particular sophistication as it relates to some quality improvement models. But if the rest of the staff is not introduced and brought on board, then you might be able to move quickly, but the sustainability of that model becomes really challenging because you don't have that team engagement. So yeah, I agree completely with that idea.
Thank you so much. And there was a question, is there a certification for NIATx?
We've actually just been doing that, where we have just emerged with certification model for change leaders, which is that role of the individual who's leading the change, and for coaching as well. I'm actually just on Monday, I'll be working with a group in New York City, sort of our inaugural group of folks who are identifying as certified. We do Change Leader Academy training all the time. It hasn't been certified. That would be through NIATx Foundation, not through TTCs. But you can absolutely go to a very structured, formalized Change Leader Academy training. Typically we do 4 90-minute sessions, 6 hours worth of training to cover the whole model and to do a deep dive on the very kind of quick sketch that I gave for everybody today.
Thank
And
you
people
so
can
much.
certainly, I'm sorry about that, Shreya. People can certainly contact me if you have questions. I'll put my email in the chat if you have further questions about that.
Yeah, we truly appreciate that. And thank you so much for this wonderful presentation and discussion. With that, we will move on to our announcements. Thank you, Kiddo. The Center for Substance Use Training and Telementoring provides high-quality education and best practices For responding to substance use, CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide, please. To claim your CME credits, you must text by midnight tonight. Please text attend 1009-5065 to 844-502-1338. Next slide. Join us for our second Texas session of the year on Wednesday, November 15th. To register, please visit texas.org/sessions. Next slide. The Texas 2024 is now officially open to sponsors and exhibitors. Texas Substance Use Symposium will be taking place on Feb 29th and March 1st in Austin. If you're interested in learning more on how to become a sponsor or exhibitor, please visit texas.org/sponsor Texas. Next slide. Join us next month to learn more about principles of people-focused data management. It'll be on November the 30th at 12 p.m. And with that, we will move on to our case for today. As a reminder, we want to hear as many voices as possible, so please keep your comments brief to allow others to join the conversation. Tanya Granger will be presenting our case today. She works with an organization that provides overarching services for MOOD clients, such as mental, medical, and housing referrals, ongoing clinical interventions, access to medical personnel at all times. Tanya, please tell us a bit about your role in the organization and what are some of the barriers that your organization is currently facing, and how can this community of learning help you today?
Okay, again, I'm Tanya Granger. I'm the alternate funding coordinator for Be Well. We have multiple funding streams here, and so they're sort of separated out in terms of coordination. I'm also an active counselor with a full caseload. We service on the TTOR side, again, multiple streams of funding. So we have TTOR, and we service a little over 500 clients here at our Fulton facility under TTOR, Medicaid, and then as well as OBOT. We also have 2 locations, one in Grand Parkway, one in Galleria, that services strictly OBOT. We also have MAT-AUD funding, so we have Vivitrol for alcohol. And we don't have any Sublocade or injectable buprenorphine clients at this time. Primarily, what we do here, what we sort of really strive to do, even with such a large census, for years I trained in crisis intervention. And one of the tenets of crisis intervention in any organization is programmatic predictability. Is it predictable how you are going to deal with your customers? And if Frank talks to Joe, did they get the same interactions, the same accesses, the same things? Where we find difficulty is when, as clinicians, because we have such a direct relationship with our caseload, we will then tend to feel that my clients need something more than your clients. And I'm going to have the same exact feeling about my caseload. And so one of the challenges is keeping the clinicians on the same page programmatically, because that stops a lot of animus in the lobby, because they talk. These folks talk to one another. And so it's very important that they feel that their services are as important and they are as taken care of as the next person. So I would say that's probably the biggest challenge, is maintaining programmatic predictability in such an individualized environment. So that's one of the things. From a funding source perspective, Medicaid and Medicare are very interesting beasts in this environment. And where we come across most of our struggles is we will find ourselves as an organization, because our sole purpose is to save lives. That's what we're here for. And sometimes we have to sort of eat it in order to do that. Now, what we mean by that is, let's say we have a person, particularly a pregnant client, who comes to us who has Medicaid, but doesn't have the Medicaid that will pay us. We're not going to send that person somewhere else. We're going to service them at a loss, right? So a lot of times it's the Medicaid, Medicare infiltrating state funding. They are on state funding and they're working and they're stabilized, and they're getting twice a month dosing schedule, which they've earned. Medicaid comes along, I've got to put you in Medicaid. I cannot have you in a Be Well funder whatsoever. And then you lose that time in treatment literally because I have to bring you in more often for my organization to get paid appropriately. So there's that. How does the organization remain, financially viable, serve the community when the antagonist is the funding sources? Right. I'm not sure if anyone else is sort of experiencing that, but to give you an example, I'll have a young lady come in and she meets all the criteria for state funding. We put her in the Be Well program. Somewhere along the line, she gets Medicaid or Medicare. We are not notified, and we'll ask them, please notify us. We'll check it. We MEV them, all those things. There's going to be a loss there because I'm not going to tell her, well, you change your Medicaid, it'll kick in on the first and come back. First of all, I can't tell you to change your Medicaid. I don't know what else you're getting in terms of resources from that funding source just to get it to pay for your mat, right? So there's that challenge there, getting them serviced without actually being able to bill for it in a real way. And we have taken that loss for a long time, and we'll take the loss because we're here to save lives. And so that's one of the challenges. The other challenge that I've seen is what resources are available to our clients. So Medicaid, Medicare, okay, they provide transportation. In theory, they provide transportation. In reality, we've got 5 clients sitting here for 4 hours waiting for a Medicaid driver to pick them up. And that is very daunting, and we will lose people because of that. They're just like, I'm not spending 10 hours trying to go get a dose, right? And even though we may possibly be able to give them more takeouts, it's not financially beneficial for us in order to do that because of the way the funding source has bundled or unbundled these products. So that as a funding stream, I think, is where we find most difficulty from a customer base, from a client base. This is where they're sort of shortchanged. We don't see that too much in TTR funding. It's pretty straightforward across the board. Be Well is very, very, we're the funder of last resort. So there's a lot of shifting we have to do with folks as their life circumstance changes. They may secure Medicaid or Medicare as they're aging or have a disability. And then that now takes them, because now I cannot have you in Grand Parkway, which is 5 minutes from your house. I now have to send you to Fulton, which is 50 minutes from your house, because your funder won't fund you at Grand Parkway. Right. So those kind of logistical things we see pretty continuously. We don't really struggle so much, I think, with retention. I was looking at our Be Well retention over the 3 contracts, and we're pretty consistently able to keep folks in the program. And I would like to say that has to do with my amazing counseling, and they can't live without me. And so they keep coming back. We all know that that's not true. It's really about easier processes, access to the medications, limited interventions that take them away from their life. The whole point of OBOT for me is that you have this high functioning life, and our job is to not be as intrusive into that, but to keep you well and give you access. So I think that that's been really, really helpful to be able to keep them in their normal daily life and not engage them on this intense treatment process, which is why methadone doesn't exist in OBOT, which makes a lot of sense. Are there any questions? I think I've got answers here, but I'm not sure what questions you may have that we may be able to sort of expound on this. So I'll just kind of open it up for questions and hope I have answers. I have someone here in the room with me that is way more versed than I am. So if you see me cheating for the answer, that's what I'm doing. I'm cheating and going to the experts. Okay.
This is Kathy. I do have a question before we start. And kudos for you on this low barrier model you have to care. I'm curious, how are the peers engaged? How do they work with the patient out in the community to sort of help them, or within to try to help alert changes in their status for their, insurance or whatever's happening?
It's interesting. We're here in the Houston area, and there's a very large group of peer specialists. I don't see a lot of them engaging with MAT clients. I think that the stigma exists in the peer-to-peer, and you can shoot me and tell me I'm wrong. But one of the things that I see specifically is peers not necessarily knowing how to engage a MAT client, because a lot of their engagement has to do with 12-step and Celebrate Recovery and things that are standard to the industry. If you're not a harm reductionist in your spirit, it's very difficult to work with MAT clients. Because the goal of total abstinence and sobriety is probably not going to exist, at least not long term. They're just not looking to clock days like 12-steppers. So what I see is that peers struggle with direction with these folks because they don't know what to do with them. Because the 12-step model is so, I'm sorry?
So you don't employ your own peers?
We do not at this time. No, ma'am. We do have MOU with the Montrose Center. We use their peer support as well as Heroes. The Sobering Center, HRC, Houston Recovery Center, also has a peer arena that will connect with their clients. So most of the people that are driven by the peer specialists come from the referral that employs the peer to peer that then brings them to us. Our goal is to expand that over time and to have that particular development, which I think would be even better because there'll be a broader understanding of what it means to be a MAT patient. It's just different. This is not the same as someone who's just in standard treatment for other substances of abuse. It's much more nuanced. And so I would say that we have not had a lot of successful peer-to-peer interventions, and I'd love to see more of it.
Thank you, Tonya, for presenting your case, and I will open up the floor.
I had a question for you, Tonya, to get us started. When you were talking at the front end around predictability and consistency, and when I was talking earlier, I was talking about borrowing ideas from outside of the field, and maybe it's because I'm sitting in a hotel right now. But there's certain things that hotels do when you come in to greet you. Certain things, and if the manager asked the person at the front desk, well, do you ask that question? Do you say those things? And the front desk worker said, sometimes. Probably the manager's going to say that's not consistent, right? Not predictable, consistent. So the question to you is, are there elements as it relates to addressing the issue of benefits that people have or insurance and or just that consistency and predictability of care? Are there things that you're focused on right now that you want to make sure that you do every time?
Yes. So one of the things, and I will credit Mr. Liddon, who is over our Medicaid Medicare program. He makes it an absolute necessity to sit down and talk with the client about what their benefits have. So many of our clients have no idea that they have transportation available to them. They have no clue. And the funding sources are not necessarily giving those information, or they're sending packets this thick, expecting the client to go through it and find it. So one of the things we do very consistently is we go very in depth with the client over their Medicaid, Medicare benefits so that they fully understand co-payments, they fully understand the group therapy mandates that Medicare creates, what that looks like in terms of their ability to have takeouts, why there's limitations on their ability to receive multiple or monthly takeouts. So that's one thing we do very consistently. The other thing is we have an amazing young lady in our front office that the clients see when they first walk in the door. And the beauty of this particular staff member is it just doesn't matter how they present. They get the same level of respect, care. If the person says, I can't read this or understand it, we will assign someone to work them through that document and explain it. So our intake process is where we get you to love us. Now, whether we can get you to come back is different, but we get you to love us when you walk in the door because we're warm, we're inviting, we're non-judgmental. We will help you through every phase of this process of getting in this door. If we're unable to do it, we will softly and hand you off to someone who can. So I think our retention has a lot to do with what happens when they first walk in the door. So I think intake is probably where we are most predictable. That is the area where we are most predictable, and it looks and sounds the same every time, regardless of what funding source you're coming into. I hope that answers your question.
I'm wondering if it will help the community to be able to respond and kind of discuss and give feedback and recommendations, is if we could just pull apart some of the discussions that you actually gave a few different highlights of different areas to think about. Maybe we could just focus on one. Is there one specific element? And then we'll circle back after that discussion to another. So just putting it out there, maybe that might help focus folks a little bit. So Tanya, do you think there's one that you'd want to bring up first?
Again, it really just sort of genuinely dealing with the Medicaid, Medicare issue. I don't know if that needs further expansion, if all Medicaid, Medicare providers should provide for MAT. Our biggest struggle is not the TTOR, not the Be Well, MAT AUD, it's that Medicaid, Medicare. That is where we struggle with, we struggle to get paid. I mean, it's a nightmare. And then unfortunately, it really will cause some people to not be able to be serviced. I mean, genuinely not be able to be serviced. And so that's why we'll take that hit from time to time until we can get you where we can get you service, because we literally cannot service you and get paid at the same time. So we have to make a decision. And 99% of the time, we make the decision to service you until we can do something. But again, sustainability. We're a business. We're a for-profit organization. And in order to service the 500 people, we got to stay in business, right? So I think the Medicaid, Medicare is probably the biggest thorn in the side of services, both on our end as well as the client and customer.
Yeah. So just to help with the community, are others finding that same exact challenge? I imagine you're not alone in that. So are others finding that challenge? And if so, are there other types of recommendations or things that you've done or things that you've considered that you'd like to do to make changes in that?
The room is awfully quiet today.
We're all stumped. We don't know what to do. And it's interesting because I really think that, anybody that deals with these funders like this is just an ongoing challenge. And we're a fairly large organization. So on some level, we can sustain ourselves even in struggles like this. What I worry about is that small provider that really just cannot sustain themselves, when they're struggling to try to get paid, but they accept these private insurance. If you have private insurance, I can't fund you, even though your private insurance doesn't pay for SUD treatment. So I just imagine we're not the only ones struggling in this process.
As you think about the funding and the payment as it relates to Medicaid, Medicare, might be helpful to think about things in the several buckets. There's the things that you can control. You were talking about the quality engagement that you provide, right? You can control your waiting room and your engagement and your strategies, which are highly impactful on retention of clients if you engage in all those strategies and are consistent with those as you described it. Then there's the things that you don't control completely, but you have some influence over. And then there are the things that are completely outside of your control or influence unless you engage in some activities external to your service delivery, which might be advocacy related to legislation, change of rule,
Yes.
etc.
Absolutely.
So thinking about what box you're really in, there's the control stuff, the influence stuff, and the stuff that we don't seem to have an impact on. And then maybe other folks can think about those buckets as well. What do you do when you're struggling with, for example, payment structures, as you described, that might make there's the desire to be more accommodating to your clientele is at cross purposes with your capacity to bill. If we make it kinder and gentler and easier, we can't bill as much money for those services. And that's a dilemma for us. How do we manage that dilemma when we're trying to maintain a revenue flow? So others might be able to think about that from that perspective, about those buckets. What do you do with those things where you maybe don't have total control, but you have a little influence, and how do you use that influence?
Matt, I was thinking too, just extending the trust that's gained at the front desk. And if it is a issue, I heard Tanya talking about how sometimes the patient may get an insurance or change insurances or receive Medicaid and not alert them, maybe put in a process at the front desk. Has anything changed in your insurance every time they come in? And then they will feel comfortable to talk about that. And then even in the front end of their paperwork to, emphasize, your services may change if your insurance changes, and it's really important for you to let us know. And that extend that relationship they build with your front office.
And that's a great example of crossing those barriers of those buckets, right? I don't have control over those things, but I certainly can manage those variables more effectively so as to maintain the relationship with my patient.
One of the things that we do in the admission process is we have a document that sort of kind of spells out their responsibilities to the specific funding source. And one of the things we'll say, if at any point you receive Medicaid or Medicare, we're going to be checking as well. But if you know this, it is incumbent upon you to let us know that, because whatever that gap is between that Medicaid and that fund and state funding, or you were in state funding and you got the Medicaid and then now we're not receiving that, we're going to have to talk about that, because without that knowledge, there's a bunch of days we're servicing you that state's not paying, Medicaid's not paying. Does that mean you have to pay? Well, at the end of the day, we know you don't have the ability to pay. So then all we're doing is putting you in debt, and we're not going to do that. So we try to sort of affect that right off top. Hey, here's what it is. This is what we need you to do. This is how you do it, so that we can capture that if it does happen. So we do a lot. Changes happen all the time. So what I do on the Be Well side, because it's a lot tighter, if you've had Medicaid or Medicare, I'm going to OTS you, because the likelihood of you getting that back is pretty good, right? And then we have some funding issues, so that there's no disruption. We just simply OTS and not Be Well on that particular individual, because the likelihood is the Medicaid, Medicare is coming back.
But I think when people are in an intake, this is one of their worst days.
Mm-hmm.
It's a hard one.
Absolutely.
To remember what's they're being told so much.
Absolutely.
And I think
Absolutely.
for no matter who the patient is, just putting in the workflow that one question every time, I think might help catch some of the folks that you're not flagging.
Very good.
Yeah, that's a good example of a very simple process shift. I know we can think about it from our own healthcare experiences. I've sometimes had that frustration. Do you have to ask me every time? Well, yeah, I guess you do, because I probably won't. I won't tell you. I won't tell you. I'll forget to tell you.
Right. You're absolutely right.
Yeah.
As a note, Rachel had put a comment in the meeting chat that she also does experience these concerns on widespread, and that they do cause delays and that impact care. So I think it's always great. They noted they don't have any advice right now, but they love the discussion. I think it might be really helpful. Something that we were talking about earlier before actually this webinar is related to policy, legislation efforts, et cetera. It might be really wonderful for this collective to consider what are the specific concerns that we really want to advocate to change, especially when it comes to state level Medicaid and then also federal level, Medicare. You can really make changes more in Advantage plans. So Medicare Advantage plans, there is more of an ability to negotiate with those, because those are individual payers. Those are private payer companies, right? And they will do negotiation, just so everybody knows. So that's a nice place to consider. And they will go outside of what traditional Medicare gives. So everybody knows that. They're also They're also open to kind of negotiate rates, just so you know, where traditional Medicare isn't. But once the collective maybe might want to get together and say, hey, these are the areas that we really want to see systematic change, or we want to have it added to services that are paid for, or how it's paid, or, you know, any of these things, then maybe as a system and as a collective, you all could actually write or propose that the state actually updates the Medicaid in some specific way. You could also propose specific legislation collectively together to say, we would like this to be done. So I don't know if anybody's ever thought of that or have done that before, but I know many of us on the ECHO Hub and team have been a part of legislative changes and efforts and lobbyist type changes. It might be a way, if that's the concern. Federally, it's much more hard and difficult to make those changes. You have to get on and make a lot of noise when it comes to changes with Medicare. And they do open it up every year for that, but you do have to have a higher level lobbying and support to make that change, just to be honest. That's what I found. But just thought I'd share that a little bit too.
Thank you so much, Leslie. And this has been a wonderful discussion. Thank you all. And Leslie, if you could please perhaps summarize some of the key points that came up in the discussion today.
Sure. So some things I do want to highlight is NIATx. It was a great presentation by Matt, so thank you. And some of those 5 specific areas I just want to restate, which is understand and involve the customer, which kind of correlates to what we're talking about today in our case example too. Fix those key problems, pick powerful change leaders related to that, get ideas from outside the organizations, like what we're doing here, and use rapid cycle PDSA. I almost feel like we're really, doing a nice symbol of that in our case discussions. But today, one of the things that was noted is looking at standardized processes, really looking at that consistency of that, looking at that consistency of quality engagement, really kind of considering walking through and kind of this mapping out process. What are those specific areas of challenge? And maybe thinking about very specific ways to really recommend changes or questions so that there is a level of consistency for those intakes that might be able to help it. And then in the end, if we don't have a lot of other types of easy recommendations, maybe there's something that collectively we could consider doing some sort of proposal for Medicaid here in Texas to be able to improve or enhance payment or reform in some way. So I don't know if anybody else wants to provide any other additional feedback or comments, and you can also provide it on the meeting chat.
Thank you so much, Leslie. And thank you all for joining us today for this wonderful discussion. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email bwltx@utisca.edu. We look forward to seeing you at our next session. Please note that it will be on Thursday, November 30th. Have a wonderful rest of your day. Thank you.